there are two papers on Better Together in public board papers today. The first is the assurance report providing an update on programme progress, and the second is the consultation plan that would be enacted should there be a board decision to move to consultation at some future point. We will present and talk through both papers before opening up for questions and comments. In presenting these papers, I'll be supported by Claire Madsen, Elaine Lawton, Adrian Osborne and Lucy Cornish. So dealing with the first of those papers, I'm going to run through a summarised set of slides. So slide 1. So today's presentation provides an update on Better Together Phase 1, focused on adult, physical, mental health community services. The purpose today is to provide assurance on progress, the evidence informing the work and the steps being taken towards presentation of the pre-consultation business case in September. It is important to say at the outset that this is not a decision-making session. No decisions have been made about the future shape of services. The purpose is to show how engagement, evidence, modelling, clinical advice, pathway testing and assurance has been used to develop and assess potential future models of care. The presentation has 3 messages. First, why the current model needs to change. Second, how evidence and engagements have shaped the emerging future model. And third, the assurance and next steps towards pre-consultation business case consideration and consultation. Next slide, please. Better Together is our commitment to work with communities, staff, partners and the public to transform healthcare services for people in Powys. The core issue is that we must change how we work if we are to continue providing safe, high quality and sustainable services into the future. We are starting with adult, physical and mental health community services because these are the services that most directly affect people's ability to remain independent, avoid unnecessary admission, recover well and receive joined up support. This includes community hospital and mental health inpatient services, urgent care, mental health access and community teams, district nursing, home first, falls prevention, therapies, diagnostic and other services that support people at home or closer to home. The work is grounded in the shared health and care strategy for Powys, developed with Powys County Council, PAVO and the people of Powys, and now has been extended to 2028 through the Regional Partnership Board. The most important point is that this is not simply a service review. It is about designing services around future need, more prevention, more care closer to home, stronger primary and community care, and better integration between physical health, mental health, social care, and the third sector. Next slide, please. The slide shows the journey from early engagement through to the current technical phase. Better Together began in 2024, and since then the programme has been listening, engaging, and undertaking the detailed work required to develop robust options. Stage 1 pre-engagement helped us understand the wider context and the challenges people see. Stage 2 engagement then explored scenarios for adult physical mental health community services and helped shape the criteria that would be used to assess options. Since summer 2025, the programme has been in a technical phase, testing evidence, developing options, undertaking modelling and building assurance around whether options are viable and deliverable. There have been delays as additional options were introduced through internal check and challenge, but this has only strengthened the process by ensuring a broader and more robust appraisal. We are now moving towards finalising options that could be brought through into the pre-consultation business case for board consideration in September 2026, ahead of consultation if board agrees. The next slide brings together the main elements of the case for change: people, place and resources. Powys is ageing. The population aged 65 and over is projected to increase, while the proportion of people of working age is reducing. This means more people are likely to need care and support, while the workforce available to provide that care becomes constrained. Nearly half of the people aged 75 and over are living with 2 or more long-term conditions, and the number of people aged 80 and over has significantly increased over the last 20 years. These demographic pressures are not temporary, they are structural. The place element is also critical. The map illustrates the scale of rurality and sparse population, with each yellow dot representing an area of Wales that no one lives in. The average population density in Powys is around 26 people per square kilometre, compared to 2,620 per square kilometre in Cardiff. This has a real impact for service design. We do not have the population critical mass to deliver every service safely or sustainably in every location. Some specialist services require a scale of staff, expertise and activity that cannot be replicated across a rural county. Long distances from large population centres also makes recruitment and retention more difficult. The resources element is equally important. Powys has a different financial profile from other health boards, with a high proportion of our expenditure on services purchased from other organisations. The implication is that strengthening prevention, community services and local models is central to quality and sustainability. For the board, the key message is that future services must be designed around prevention, independence and coordinated community support, not simply more reactive or hospital-based care. The next slide brings together the key elements from stage 2 engagement. The central message is that people are not simply opposed to change. They want change to be purposeful, evidence-based and grounded in what matters locally. People told us they want stronger primary and community care, an integrated approach, prevention and early intervention, compassionate end-of-life care delivered by skilled staff, and strong partnership between health, social care and the third sector. They also recognise that some services may be organised differently, including through centres of excellence or regional rural centres, and that some specialist services may need to be delivered outside of Powys where that achieves the best outcomes. But they were also clear that services must remain equitable and rurality, transport, digital inclusion and access must all be considered in the plans. A key point from the local voices slide is the published papers, is that there is a strong civic pride in local services, including the contribution of communities, volunteers and unpaid carers. People also raise concerns about equity of access, travel to district general hospitals, cross-border care, communication and information following the patient, loneliness and isolation. Therefore, the emerging model has to do 2 things at once: protect what people value about local care, while creating a more integrated, preventative and sustainable model in the future. I'm now going to hand over to Claire. Thank you.
Thank you, Deb. Thank you, Deb. So my name's Claire Madsen. I'm the Executive Director of Allied Health Professionals, Healthcare Scientists and Digital. And this slide is particularly important, bearing in mind Katie's comments, because it demonstrates how the case for change is about quality and outcome for our population, not just capacity and finance. And the evidence on deconditioning and delirium shows that prolonged hospital stays can cause real harm to people, particularly for older people and people living with frailty. Slide highlights that up to 50% of older people may become incontinent, for instance, within 24 hours of admission. 50% experience functional decline, and between admission and discharge, 61% of old people develop a new disability and are not back to their usual level of function after 1 year. So the implication from this slide is clear. Hospital care remains essential for our population. However, it should be focused on people who actually need hospital care, and it should be time limited. They should be just there for the right length of time. where it is safe and appropriate, helping people remain active, independent and supported at home in their own community can improve outcomes significantly. Next slide, please. So the national evidence tells us that unnecessary or prolonged hospital care can cause harm, but we also have data from Powys that shows why this is important as well. We continue to see high levels of hospital activity, long lengths of stay and increasing demand from people living with frailty, dementia, multiple long-term conditions and complex physical and mental health needs. The slide shows over 37,000 out-of-county admissions, generating almost 100,000 bed days in 24-25, and the average community hospital stay is around 40 days, which is almost double the Welsh expectations, which say we should expect around 21 days. It also shows that almost half of the people in our community hospital beds are clinically ready to go home, demonstrating the need for stronger community alternatives and discharge support. The fuller presentation in your papers also shows that includes patient pathway testing, a rapid review of community hospital inpatients, and a week of care review of emergency admissions. That testing showed that a significant proportion of hospital activity could potentially be prevented, shortened or managed differently through a stronger community-based model. But the key point from this slide is that the case for change is not based on one source of evidence. It's supported by national evidence, local data, pathway reviews and engagement. Together they point towards stronger prevention, earlier intervention, integrated physical and mental health support, more care at home and better rehabilitation and recovery in the community. Next slide, please. So this slide is also important to emphasise that the future model is not starting from scratch. There are already important building blocks in place across Powys. These include access developments such as our single point of access, our 111+2 service in our mental health services, and our digital services. Prevention work around frailty, early intervention, and community support, and alternatives to admissions such as our virtual wards and crisis response. We have recovery and independence services such as reablement, intermediate care, and discharge support. And we have increasing integration between physical, mental health, social care, and we work closely with our third sector organisations within Powys. Better Together brings these developments together into a more coherent model. The aim is to move away from fragmented or isolated schemes and move towards a system-wide approach that can be consistently understood, resourced and delivered. So the message for Board is one of both confidence and realism. There is already progress to build from, but the evidence tells us that incremental improvement alone will not be sufficient to meet our future needs. I'm handing over to my colleague Elaine now.
Thank you, Claire. So this slide shows the structured route that we've taken from case for change to consultation. We started by identifying challenges and opportunities through the case for change, supported by technical chapters on community services, primary care, mental health and diagnostics. And we then moved into ideas generation through engagement with citizens, staff, communities and stakeholders. Those ideas then needed to be translated into options. Hurdle criteria were used to test whether ideas were feasible enough to proceed. Assessment criteria based on the duty of quality domains, safe, timely, effective, efficient, equitable and person-centred, were then used to test those shortlisted options. These criteria were informed by user and staff feedback during stage 2 engagement, so they reflect what people told us matters. The fuller deck also sets out the assurance underpinning this work, including staff and user insight, benchmarking, independent clinical advice, demand and capacity modelling, strategic assessment, and partnership working. It also referenced learning from other service change programmes, independent advice and assurance, independent consultation insight, CLICE, and staff side participation and external review. The key assurance message is that options are not being developed through preference or opinion. They're being tested through a structured, evidence-based, engagement-led and independently challenged process. Next slide, please. This slide brings together the emerging future model across mental health, physical health and urgent care. The important message is that these should not be seen as separate models, but as parts of one integrated physical and mental health community system. The mental health model is described as an integrated recovery-focused system, an early intervention and no wrong door access. It spans prevention, crisis, inpatient care and recovery, with a strong emphasis on community-based support, crisis alternatives and integration with physical health. The physical health community model focuses on proactive prevention, rapid, time-limited intermediate care, multidisciplinary place-based teams, urgent community response, rehabilitation and hospital at home services. It's designed to improve independence, reduce avoidable admissions and enable safe discharge. The physical health inpatient model is not about saying beds aren't needed. It clarifies the role of inpatient care within a wider system, a step up, step down, rehabilitation, complex care, mental health inpatient support and end of life care where that's required. The urgent care and diagnostic model strengthens timely access to assessment, diagnostics and treatment for non-life-threatening conditions, aiming to reduce avoidable emergency department attendance and unnecessary travel out of county where that is safe and appropriate. So the overall shift here is from fragmented pathways to one coordinated approach. Earlier prevention, simpler access, faster community response, inpatient care focused where it adds most value, and stronger recovery and independence. Next slide, please. So behind all the modelling, analysis and option development are real people like Delith. So Delith is 75. She lives independently on a farm in Powys. Welsh is her first language. She's got vascular dementia and experiences delirium during a UTI, raising both physical health and mental health support needs. Today, Delith's pathway risks becoming fragmented. Physical and cognitive decline may be recognised late. An acute episode may be managed outside of Powys. Her family may carry the coordination burden, and inpatient care may be considered separately from wider support at home and in the community. The future model is designed to feel different. Instead of multiple services and multiple plans, Delith would have one coordinated team around her, bringing together physical health, mental health, independence and wellbeing needs into a single pathway. This means more support to stay safe at home, earlier intervention when her needs change, integrated monitoring and step-up care, and specialist inpatient care when that's required. The slide also highlights better continuity and support for individual needs. This is the practical meaning of the future model: less fragmentation, fewer handoffs, more support at home, and one joined up team working together to help people stay independent, well, and connected to their community for as long as possible. The message from this slide is important. Better Together is not simply about changing services. It's about changing the experience of care for people and families, from navigating separate pathways to being supported through one person, one plan, and one pathway. Thank you. I'm going to hand back to you now, Deb.
Thank you. So next slide, please. So no decisions will be made until there has been full and meaningful consultation with the public and staff about the future of community services in Powys. The consultation is expected to ask important questions about how we ensure a greater focus on preventing ill health, how we strengthen primary and community services so that more people are supported to stay well in Powys, and what the right future model is for bed-based services. A pre-consultation business case is currently in development and will be brought to board in September for a decision on whether to proceed to consultation. If board agrees, consultation will then provide the opportunity for formal public and staff feedback before any future decision is made. The key dates are: board papers are published in the week beginning the 7th of September. Board decision on launch of consultation is on the 16th of September. Public consultation will run from the 21st of September to the 13th of December, and then we enter a period of conscientious consideration of all of the feedback in Q4 of 26-27. A post-consultation business case will be considered by the board in spring 2027. In closing, the evidence, engagement and assurance work to date all points towards the same direction. Future health and care needs in Powys are most likely to be met through a stronger focus on prevention, integration, recovery, community-based support and care closer to home, whilst ensuring that inpatient and urgent care services are available when needed. As a reminder, the board has not been asked to make any service change decisions today. The board is being asked to take assurance that the work has progressed through a structured, evidence-based and engagement-led process, and to note the route towards pre-consultation business case consideration in September. I'll now move on to the second of the papers, and this second area is the consultation plan that would be used should there be a decision to proceed to formal public consultation. If we now turn to that paper, and I'll be supported on this item by Adrian Osborne. So together I'm introducing the proposed stage 3 formal service change consultation plan for Better Together phase 1, and seeking the board's approval of that consultation plan, whilst recognising the pre-consultation business case itself will not come before board until September. I'd like to begin by emphasising that this paper is about how we will consult and not what decision the board should ultimately take about services. As stated earlier, no decisions have yet been taken on the future shape of adult physical or mental health services in Powys. Today's discussion is about ensuring we have a robust, transparent and legally compliant process in place should the board decide in September that options are ready to proceed to formal consultation. If I may, I'll now hand over to Adrian.
Thanks so much, Deb. So I guess, as we've heard quite powerfully there, our health services in Powys face some significant opportunities and challenges if they're going to be safe and sustainable for the future. And I express an interest here, as many of us do. I'm an ageing Powys resident, so bluntly, I've got a few years of my remaining working life during which I can help create a health system in Powys that I and others feel safe to grow old in. And that's certainly something that focuses the mind right now. So the scale of the potential options that we're considering are reflected by the model of care we've just heard about. These definitely reach the threshold for formal consultation set out in Welsh Government guidance on service change. There's a detailed guidance available online about what form and nature that type of consultation should take. And as Deb said, I stress that consultation will only take place if it's approved by the board following consideration of the pre-consultation business case in September. But ahead of that recommendation, it's vital that we do start some detailed planning so that we can ensure a fair and compliant consultation process that enables our citizens, our staff, our partner organisations to understand the work that's taken place so far, to test it, to ask challenging questions so that decisions can be made next spring that take full account, take conscientious consideration of all that's been heard. So the consultation plan presented to you today sets out the framework in which those activities take place. It's been developed to reflect recent legislation, relevant legislation, policy, best practice advice. We have independent assurance in place from an organisation called HICO, with their feedback being fully reflected within the plan in front of you. The plan has also been developed and reviewed through our organisational development, engagement and communication work stream, and that includes staff side and CLICE participation, CLICE clearly in an observer role, reflecting their independence. And again, the feedback that we've received has been fully reflected in the document before you. So I guess a key question for the board is whether this plan, if delivered, would enable us to meet relevant compliance requirements, essentially both to undertake a satisfactory consultation and therefore also mitigate future risks, for example, in relation to challenge or a judicial review. So, for example, it's vital that we set out in this plan the activities that we can deliver, have capacity to deliver, and are sufficient to meet our requirements. I know there's lots of things that we could do for a consultation, but this focus on the things that we must and should do, and these form the focus of the plan. And it's also important that we reflect and review during consultation, particularly at the midpoint, so that we identify and agree further steps that we need to take, reflecting on our learning of delivering the consultation plan so far. So based on the assurance processes that we've had in place, my recommendation to whether the board can approve this plan is yes, this sufficiently meets our relevant compliance requirements. And some examples in the plan include there will be a public drop-in event in each of the 13 Powys localities, reaching out to communities across the county. There'll be outreach to community groups to ensure we hear voices less heard. There'll be public focus groups that are independently facilitated by an external analysis company, ORS. There'll be inclusive materials such as easy read, audio, and there's a wide range of accessibility features built into our website as well as providing print information for those who need it. As I mentioned, the plan includes independent analysis from ORS of the views that we hear, and I think this will give the board and the public greater confidence that the issues raised are being presented to us independently, and we are hearing the issues that people are putting to us. And importantly, in the plan, it also expects that we give time for that analysis, that we ensure as a board conscientious consideration of what we've heard, and that the conscientious consideration is seen to inform the post-consultation decision case before any decisions are made. Clearly, alongside this, the role of LICE is incredibly important as an independent citizens' voice body, hearing views from the people of Powys, which will also contribute to their own responses and representations, which the board must have due regard of. So in relation to this plan, there are a couple of issues and risks just to draw the board's attention to. If we are to launch consultation on this schedule, we will incur some costs associated with consultation ahead of that September decision, because it's important that we plan and enable people to respond, as we've so clearly heard from LICE and members of the board earlier. So, for example, we will need to begin to advertise some activities such as locality drop-in events ahead of the board decision because we want to give residents enough time to plan to attend. So the board's asked to approve the consultation plan today, noting that it doesn't prejudge or preempt any decisions to be made at the board meeting in September when the pre-consultation business case is received. Instead, today's decision is about confirming the framework through which consultation would be delivered so that detailed planning can now take place in readiness for your decision. And this will also be an open and transparent process so that we share with the public how their feedback informs the recommendations following consultation. That's so important that we're seen to share the independent analysis of what we heard, that we demonstrate how that contributes to the post-consultation decision case, and that we feed back to our communities about their voice is informing and influencing the decisions the board makes. So I therefore commend the plan to the board today for approval.
Thank you both. Deb, does that conclude your presentation, or do you have any closing remarks?
No closing remarks other than to say, a big thank you to the team for supporting today and for the teams that are not even present that helped to get us to presenting these papers today. But I'll hand back to you, Chair, for any comments, questions from others.
Thank you. Robert, please come in.
Thank you. First of all, on the communication plan, it's very thorough, reflects the considerable expertise and experience of the team, and I have confidence in that plan. As always, a huge amount of work being done in the background on Better Together. I'd just like to make two observations on preparing and presenting content for the further discussion, and if these are If this will appear as a teaching a grandmother to suck eggs, and I apologise, but I think some of the issues will resonate with members of the public. First of all, we have to have unambiguous clarity on the exact nature and the impact of any proposals when the time comes. For example, the inclusion of alternative ways of accelerating urgent care is very interesting. We've had these types of plans, MIU Plus, in our strategic plans before. Urgent care centres are mentioned. There'll be lots of interest in this, what they will and will not do. We don't want to unjustifiably raise expectations, what added value they will bring, what exactly can we do within Powys, within our budget. I'm sure that future plans will make these things clear. And second, Better Together is a programme that develops alternative ways of doing some things, but it also relies on continuing to do some things well while demand increases. So the success of any proposal depends on there not being a weak link in the chain. Take, for example, general medical services. Is there parallel innovative work being done to ensure that the capacity of that service is likely to be able to support the growing elderly population, and so complement and not hinder the proposals that will emerge from Better Together? I acknowledge the phrase strengthened primary care in the document, but I think that the concrete details of how precisely that service will be maintained are as important as a description of the new ways of working that will emerge from Better Together, especially since primary care is already a red scored risk on our risk register. I think we should include that assurance at the same time as the detail of the other Better Together proposals. This may well, of course, be the plan, but I do believe that this subject will be of substantial interest to all Powys residents, and that addressing it in our consultations will confer even more credibility to any Better Together proposals. And of course, we could make similar comments on delayed transfers of care, which also has the potential to severely reduce the benefit of any changes. Thank you, Chair.
Thanks, Robert. Deb, do respond, or bring in others to respond to Robert's comments and questions, please.
Lovely, thank you. Can I bring in Lucy on Robert's points about weak link, etc., and then Elaine for primary care?
Thank you, Deb, and thank you for your questions and comments, Robert. So just in terms of your request for unambiguous clarity on the models and expectations around future models of care and the detail, particularly in relation to the scope of urgent care provision, etc., that will all be included in full through the pre-consultation business case that is presented to board in September, and then through into consultation materials, so that we can provide the clarity in terms of the proposed scope of services and our confidence in the ability to deliver those, and the impact of that on the population. Just providing assurance around that, Chair. I know Elaine's going to come in relation to general medical services and primary care. I think just to note that we are aligning our plans with national work around community by design, and the emerging plans around that, to ensure that our community model that is in development supports those initiatives that will further drive that improvement through primary and community care in the future. But I'll hand to Elaine. Thank you.
Thank you, Lucy, and Robert, thank you for your question. I think the point around general medical services is really critical. I think there's two key components of that. So the first of those is, what is it that we can directly influence around how individual general medical service providers, so our GP practices, evolve and develop and can respond to the ageing demographic that we have, not just within Powys but across Wales, but increasingly so within Powys. And I think some of that we can influence, some of that is led by the national negotiating teams that hold and manage the contract development. And there is commitment at this point in time in terms of developing general medical services. I think the critical bit, though, that we can really make sure that we can deliver through Better Together is how we develop that community model, how we build that and wrap that around and with general medical services. I think that's got to be the most important element. And when we have conversations with general practice, a lot of their decisions are made on what they know about the services that they can access outside of their building for their patients, for our population. So that's a critical component part of the community model that we're developing and proposing through Better Together.
Thank you. Robert, do you have any additional comment or question?
No, thank you. Thank you very much.
Okay, let's go to Simon, please.
Thank you, Chair. I had three comments and questions around the consultation plan, if I may. So first, thank you to all of the teams. There is a significant body of work going on here, and this presentation today really does shine a light on just how much work has taken place already and how far along that journey we've come, and how strong the due diligence has been in looking at the options and building the case for change and the consultation plan. So thank you for that. I was really pleased to see the Delith story in the presentation today, and that really prompted me to just ask and seek some assurance that we're going to be able to see some more of those kind of persona stories developed as we go out to consultation. They really do help, I think, to explain how things will improve for individuals in their communities. So I'm keen to see more of that as far as we're able to develop it. Similarly, wanted to check, are we progressing an assessment of what the changes might mean for individual communities? We saw that coming through some of the deliberative event feedback. So just wanted to check how far we're able to progress some of that thinking in the consultation. Third point I wanted to pick up was a reference in the consultation information around consideration of further events, and I'm very mindful that we do have limited capacity and we can only work within the capacity that we have, and that will we have some clear criteria by which we're able to judge whether or not we can undertake additional activities and additional events, given the high level of interest there's going to be from a very broad geography and quite a lot of perhaps more local structures seeking to invite us into events that they're running. Also being mindful that we have to be careful not to create inequality in terms of attending an event in one area and then because we haven't been invited to not being present in equal terms in other areas. So just mindful that we need to be careful about that. It's just really a check whether we're going to make sure we've got some kind of criteria by which we'll judge if we say yes or no to invitations that may come in around additional activity. Thank you, Chair.
Is that back to you, Adrian, initially, or?
Really happy to come in on those. Yeah. Yes. I think on the personas, that's a simple yes. We're working on a range of case studies that help to bring to life the potential impact benefits, but also potential downside impacts of the options that are under consideration. And linked to that, very much anticipating that within the consultation information that's published, we'll be seeking to identify the impacts on a locality basis. So colleagues are aware that we tend to plan on a 13 locality basis within Powys in terms of population planning. So we're looking at an impact statement for each of those 13 localities. Ideally too, as the consultation progresses, not necessarily at the outset, but as we move forward into those locality events, actually having some of those persona case studies on a locality level as well, so that as we're visiting each community for those drop-in events, we're able to explain on a more granular basis what that might mean in that community, recognising Powys is large, isn't it? Our experiences in different parts of the county vary a lot. The pathways in Fachlan, Llanrydr and Mochnant will be so different from those in Ystrad Gynllais, Hay-on Wye to Machynlleth and all points in between. So trying to provide that localisation is something we very much aspire to. Important point too about events, and fairness is that real starting point. So the consultation plan is very much based on that fairness of us proactively reaching out, about us seeking voices less heard. If we're too drawn by saying we'll attend this event, that event, the other, then we risk giving preference rather than fairness. A key point in the process will indeed be the midpoint review, because actually that midpoint review is a really timely opportunity to say who are we hearing from, who aren't we hearing from. So therefore, where there is discretionary capacity to do more, then we target it into the areas that we haven't already been hearing from during the consultation, to really build that idea of fairness and voice right into the heart of this consultation, so that we give people confidence, they've had the opportunity to contribute, and we give people confidence too that those voices will be influencing the decisions that are made following that consultation. I hope that's helped.
Really helpful, Adrian. Thank you very much.
Right, let's go to Mick. Please, Mick.
Thanks, Chair. I think in a sense, my observations and a couple of questions that have largely been covered, but I think, this is a really significant issue for the board, and I think it's probably worth just sharing perspective so there is a range. So for me, this was a really helpful and very timely paper. Actually, I've followed the progress of Better Together incrementally over the last 2 years, and, it's been a challenge to keep pace at times, but this paper for me, in conjunction with the paper in the private part of the meeting, it just brought it all together in a very cohesive and compelling way that I found relatively easy to follow and understand. So I wouldn't say it was a light bulb moment, but it certainly, brought things to life for me. I think the papers and the presentation make out, the case for change in a very persuasive way. And in particular, I'm reassured, I'm assured that a great deal of thought has gone into designing what, by any standards, having seen a few of these, is a very comprehensive and very wide-ranging consultation process. And one which genuinely puts stakeholders and public participation at its heart. So in that sense, just to nail my colours to the mast, I'm very content to support the recommendations and very content to approve the consultation plan. I just had two questions and observations, which Robert and
Simon.
Sorry, Simon. Robert and Simon covered, but I think more to do with how we're going to do it rather than what we're intending to do. So the first one was around community concerns that decisions have already been made. You raised that in your opening comments, Carl. Kate alluded to that in her input. So just a question in my mind about how we're going to give our communities the same level of confidence that I think we have as a board, that this is genuinely a point at which they can influence the eventual outcome, rather than just comment on things that are largely settled. I don't think an impacted presentation like the one we've had today or a detailed paper is going to do that. It's something more intrinsic that will convince people that this is a genuine opportunity. So just, interested to hear any further thoughts on that. And then the second question for me was, the options for consultation are, by virtue of the fact that we are genuinely seeking people's views, they're quite broad. And as Simon alluded to, it might be quite difficult for people to envisage what that means for them on a day-to-day basis. So I was just interested, as Simon was, and we've discussed this, how we bring this to life for people, how we make them able to see what it is that this means for them. And we did have quite a detailed conversation about it at Board Development Day, but it's helpful, I think, to rehearse it in a public domain. And I suppose, just a final observation, time is now of the essence. We're a month away from September when the board will need to approve this. So there's just a question about what's practical in terms of bringing this to life, making it feel like a genuine opportunity in that short space of time.
Thank you, Mick. Again, is it Deb? Should we go to you first, or do you want to hand over to Adrian?
Excuse me, I'll try and respond first. So in terms of giving the communities a kind of, I don't know, genuine understanding and making them feel part of it. What Adrian's described is helpful in terms of getting out there. We've also stood up more regular conversations with our staff, lots of whom will be members of those communities. So one, to make sure that they understand where we are in the process. Secondly, that they understand kind of perhaps some of the misinformation that might have been kind of put into public domain, but that they have an opportunity to influence and hopefully be a voice in their family group, their community. In terms of the bringing it to life, you know, we acknowledge that not everybody is going to read really long business cases, but it would be really important that it is in easy everyday language, that means people can understand it. It will be supported by some visuals which describe things like the Delyth journey, so in those personas. So I wouldn't want people to be concerned that because they haven't seen all of that today, they aren't things that we're working on behind the scenes in anticipation of where we might be in September. I don't know if there's anything else you wanted to add, Adrian.
Thanks very much, Deb. Really, really important points there. And I think it acknowledges that a challenge for all of us when we launch consultation is that this is not a referendum. It's a vital and timely opportunity to test and to challenge ideas that have already been informed by thousands of voices over the work that's taken place over the last 2 years and even previously. So I recognise there will be some of those issues in public confidence about the degree to which they can influence decisions, because again, as we've heard in our earlier presentations, our consultation is likely to focus, subject to the views of the board in September, on a suite of options. This isn't now a blank sheet of paper, because a lot of very detailed work has been undertaken to think what's clinically feasible, what's safe, what's viable, what can we make happen, and how do we adapt that into the very unique challenges and opportunities presented by a county like Powys, where we have no feasible opportunities to provide, for instance, a district general hospital within the county. We don't have a large enough population with a critical mass. We have to find new and unique ways to do that suit our context. So having that suite of information, enabling people to access visual, simple, easy read versions as an entry level, drill down into the detail. The papers that the board receives in September will be a suite of very detailed technical supporting documents as well that help those who wish to drill into the detail of the very careful consideration that's already been taken of demand, capacity, workforce, finance, travel, clinical compliance and clinical governance. That detail will be there for people to scrutinise, and hopefully that will be a key part of the confidence that we can give to people as well.
You content, Mick?
Yes, thank you. That's helpful.
Thank you. We do have several colleagues still wanting to contribute. I am conscious that we are running significantly behind time in this meeting. However, these matters are very important, and it is equally important that we give them the time that they deserve and the time that they need. So I'm not going to stifle discussion in any way. I would please ask for brevity, and if anything in terms of question and so on has been asked before, then please try not to repeat it. But let's go to Steve. Thank you.
Thank you, Carl. Yeah, just very briefly, just to support other colleagues' comments, and in particular to support the comments about developing other personas. I think that's really important to bring that to life. A specific question in terms of the consultation plan was how we intend to engage with our primary care colleagues, because they obviously have a critical role to play in bringing the future models of care to life. So I know they're referenced in the plan, but I didn't see anything quite as specific about how we will engage with them, you know, separate to other engagement processes. So perhaps if you could explain that. Thank you.
Thanks, Steve. If we just hold on to that specific question, please, and invite Rhiannon to make her contribution.
Thanks, Carl, and also acknowledging the maturity, I suppose, in terms of this particular slide deck. I think it's really helped to bring the confidence and bring the strands together. My 2 points specifically is around how are we looking at the cumulative impact on communities in the context of any transformation programs that the council is having, particularly that sort of, what we're doing, what they're doing, and the potential of cumulative impacts, positive and potentially negative. And my other point really is around prevention. Quite rightly is mentioned a lot in the presentation. But I think it's really quite important that we distinguish whether we're talking about primary prevention or secondary prevention. My understanding is I think we're really talking about secondary prevention. The types of things that Robert was talking about earlier in the kind of early years aspects of obesity pathways, shifting money into prevention that actually takes a lot longer to be realised. It is a different kind of lens on prevention. So I think it's just being clear about earlier intervention, prevention across the life course, probably more in the sort of upper age range of prevention. Thank you.
Thank you. Deb?
Can I bring Lucy in, please, Carl?
By all means.
Thanks, Chair, and thank you for your questions, Steve and Rhiannon. So just in terms of response around the primary care engagement, we have a wider pre-consultation engagement plan with all our partners and providers, of which primary care and GMS colleagues are a key partner. So we have, over the course of this work, run a series of quarterly workshops with our primary care and specifically GMS colleagues, recognising where we are in the process. They have also been invited to participate in our deliberative events and other engagement activity. We have had a recent workshop session, so half-day workshop session, since our deliberative event with primary care colleagues, and are in the process of booking a series of practice level discussion sessions over this coming period so that we can have further conversations at a practice level. We are engaged with a collaborative and cluster level also, and then have further workshop sessions scheduled in over the coming months into the next 2 quarters as well, where we will be further continuing this conversation, but at a more specific primary care GMS level. So hopefully that provides assurance in relation to that aspect. I will add that provider and partner engagement plan also includes all of our providers and wider partners as well, to ensure that we are having those ongoing conversations with all of our partners and giving them the opportunity to both engage and participate alongside the consultation period, which, subject to approval, will go live in September. So just then in relation to...
Lucy, I'm sorry to interrupt. Can I just ask a bit of clarification? When we talk about primary care, are we talking about the breadth of primary care? So you talked about workshops and events and so on. Or are we talking specifically about GMS and GP practices?
So our primary care workshops have included wider invitees, but they have had a GMS focus. So they have included invites to collaborative leads from all professional collaboratives within the clusters, but with invites to, at a practice level, to all practices to send a representative. So they've been primary care sessions with a GMS focus, Carl, and the forthcoming sessions will continue with that format, also with the GMS focus, but wider primary care representation also, and then those practice level discussions will obviously be GMS focused discussions.
Thank you. Sorry, I interrupted you, Lucy. You were going to go on.
That's okay. Thank you, Chair. So just moving on to the questions around the cumulative impact with social care. Just for assurance, we have a regular interface with our partners and particularly with our adult social care partners. We have identified some areas of joint priority for working and have our interface through both joint leadership team, but also through separate transformation related discussions and meetings to ensure that we are aligning in terms of our planning. So those are in place, and at this point in time we're not identifying any conflict in planning that would lead us to consider that there are any challenges in relation to the elements that we are seeking to take forwards into consultation. In terms of prevention, absolutely acknowledge the comments around primary versus secondary prevention and the need for clarity in relation to that. We obviously have the board approved population health framework, which we will be seeking to reference within our pre-consultation business case as an important background document and framework for the organisation, which links through to Better Together as well. Thank you.
Thank you, Lucy. If there are no other, Steve, you, Rhiannon, you content?
Yes, thank you.
Yes, thank you.
Okay, let's go finally then to Kathy and to Chris. Please come in, Kathy.
Yeah, Kathy Poynton, independent board member for trade unions. I don't particularly want to ask a question, but would like to inform colleagues about staff involvement in Better Together and the process that's gone forward. What we have to remember is staff are for change. They want the change. They were asking for changes before Better Together was started. So they have been involved in the main, not all staff, I will hold my hands up there, in giving ideas, in giving feedback. They have attended team meetings, departmental meetings, service meetings, plus the deliberative events and anything else. and they fully understand and want to embrace a change because they know their contribution and what they put forward will make an improvement to patient care, their working lives, and the quality of care that patients receive. So while not everybody is happy about it, I would say that the majority of staff are, and that they do actually realise this is, hate to use a managerial term here, but this is a marathon and not a sprint. And they know that big change takes time, but they are all for it if it will improve what they can do during the day. And a lot of them being very impatient that they want to see this change happen now.
Kathy, thank you so much. That's a really helpful contribution. And just for those that may not be aware, I think particularly having your input as our staff side and trade union independent member on the board is particularly helpful and useful. So many thanks. Chris, please.
Thank you. I can see that a process has been followed, and I also welcome the communication plan that's mentioned in particularly around the outreach proposal, because I think it's really important that we can engage with those people that may not be digitally active so that we get their inputs within it. I think it was mentioned that we're going to take stock in around the halfway stage to those where we've got gaps in that consultation. And I just wondered whether there's any lessons learned from previous engagements of where we note that there is a particular group or contribution that doesn't come in, it's limited, so that whether we can work proactively to address that going forward. I think that we also need to focus this around, there are people that are utilising services in the here and now, and there are those people that are going to be accessing services going forward. So therefore, if it's going forward, we can put the preventative model in, which is in place, and it's how we fit those two pieces together, because they could be repel and they could become poles apart, and I wouldn't want that, because the most important thing in my view is that we have safe and effective care which is of a high quality in whichever direction we go. I was also interested within the integrated model. I think that is really helpful, and it's not just about better to get together, it's also about working together. So my question was, and I think Lucy gave some of the indication that there has been work with the local authority, and I welcome that, because that partnership collaboration is really key and important, because a change in the local authority can also then have an impact on the health board as well, and vice versa. And on the but yeah, I can see that this has been worked through. Finally, if we have these consultations coming through, just picking up on a point that was made earlier about dual consultations going on with another body, does that confuse things and could that put us off track? And if any ideas do come through from these events, how are they then going to be worked through? Because if we leave it until the December before that's then considered, does that then give us enough time to reflect on that and work up any additional proposals that the board would then need to consider? And I'll stop there, Chair. Thank you.
Thank you, Chris. Some observations and one or two questions, but let me come to you, Deb, and you bring in whoever you think is best placed to respond.
Lovely, thank you. I'll hand over to Adrian and Lucy for Chris. But can I just pick up on Kathy's points? I think it's really important to understand the extent of conversations that have taken place with staff. More to come, I know, but really important that we understand the staff view, and that, you know, lots of people have been asking for a change going forward. What we change to, if we change, it remains to be seen, but that engagement with staff and staff side in particular is important. Lucy, Adrian, do you want to pick up on Chris's point, please?
Thanks. Some really helpful points there. I guess across a county like Powys, one particular cohort that I would draw attention to where we'll need special attention, carers is a great example, isn't it? Carers by definition have less opportunity to leave the home. They've got caring responsibilities, making sure that we take active steps to reach out to them, potentially given the impact of these types of proposals on them, will be an area that we'll want to ensure focus on. And I include within that young carers as well. Important for the board to recognise that these proposals mainly relate to adult physical and mental health community services, but there are a couple of really important interdependencies that affect all age services as well. So we're talking about minor injury units. Minor injury units in Powys are open to anyone age 1 and over. We're also referring to some all-age diagnostic services as well. So our consultation will need to make that clear, and our consultation therefore needs to reach out to children and young people, both the service users as young carers, as the future adults as well. Really important audiences there. You raised some important points there about options. I mean, this is exactly the purpose of the consultation. As I said, this isn't a referendum. There's something here about really testing, retesting and testing the thinking that's taken place so far. Have we missed important options? And as part of the supporting documents, we'll be making clear some of the options that we've considered and why some have been discounted. Have we been using the right criteria to judge those options? Are there important factors that we've missed? We will be listening to that in real time as the consultation takes place, but it's also really important that we give due regard to the aggregate of it. Take account of that when the consultation ends. What have we heard during that 3-month period? That's why those phases of analysis, including independent analysis, are careful and conscientious consideration as a health board, and then that informs the post-consultation decision case, which we should expect to see in the spring. So December is the end of the period of the consultation based on the current plan, without prejudice of the decisions of the board. But those following months are the ones where we do exactly that. What new options have we heard? What new factors do we need to take into account? How does that then help us to develop an updated suite of recommendations to the board in the spring? And we can also look to our neighbours on that as well. So Hywel Dda, for instance, last year undertook a very comprehensive consultation across 7 service areas. In one of those service areas, they had identified new options, so have recently been retesting those, as was referenced in the Chief Executive report earlier. You mentioned too about some of those sort of interdependencies and confusion potentially with other consultations taking place. That is something we always seek to keep track of, and there'll be something really important for us, particularly in our consultation events, about them keeping them focused on this consultation. People may well come with other issues, but we will want to keep some ring fence around it so that we reduce the confusion rather than increase it. Sometimes in these events people say, well, can I bring this issue, can I bring that issue? We've got to try and make sure these help us consult on these really significant and important issues, because it's so vital, isn't it, given the challenges that we face, given what we heard from Kathy about those experiences from our staff, that we make some decisions that truly help us create safe, high quality, sustainable services for the future. The longer this takes, the more we're sitting on those very risks that you have in the corporate risk register that are affecting quality, they're affecting safety, they're affecting outcomes, they're affecting working lives across the county.
Thank you. Do you have anything to add, Lucy, before we invite Deb? No? Okay. Deb, do you have any closing comments?
No, I don't, other than just to thank everybody for their important contributions and comments. Clearly, we still have a process to work our way through, so lots of activity in the coming weeks, but I'm conscious we've taken up quite a bit of time on this agenda, Carl, so I'll hand back. Thank you.
But quite rightly so, and a big thank you from us to you, Adrian, Lucy, and the teams and colleagues behind you for bringing us to this point, which has been no mean feat in and of itself. And so, so colleagues, let's go to the recommendations. We have 2 papers for our consideration, as we've acknowledged. I'll take the recommendations separately. So initially, on the assurance paper, we're asked to note the updated position. We're asked to take assurance in relation to the progress towards presenting the options for phase 1 of Better Together. And we're also asked to note the timeline for presentation of the pre-consultation business case to us as a board, currently due in for our September meeting. So would you please indicate if you want to comment on that recommendation or dissent from it? No one is doing, so I therefore assume that that is supported unanimously. And secondly, the consultation plan paper, we are asked to approve the consultation plan, recognising the pre-consultation business case will be considered by us as a board in September. We're also asked to note that the review and assurance of the consultation plan continues to be undertaken by our external consultants, HICO. So once again, colleagues, please indicate if you want to make a comment or if you want not to support the recommendation. That therefore also is approved and supported unanimously.